Cloud. Okay. And then I'm going to do my audio separate in 3, 2, 1. Hi, everyone. Welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today with me, I have a return guest. Her name is Dr. Debbie Rice, and she's the Director of Clinical Education at Precision Analytical, the developers of the Dutch test. Dr. Rice is a naturopathic doctor who maintains practice where she focuses care on pediatric health, hormone health, thyroid health, and adrenal health. She has had experience working with communities in need, both in the United States and internationally. Her training has been primarily in women's health, pediatric care, hormone therapy, and hormone function, as well as complementary adjunct care. Dr. Rice utilizes multiple modalities, including diet and lifestyle, botanical medicine, and conventional approaches that meet the patient where they are in their health journey. And Dr. Rice's passions include activism for access to healthcare, yoga, and exploring nature. And I invited Debbie, I guess I can call you Debbie now.
Absolutely. Please.
Um,
Yes.
I invited Debbie back today to talk about estrogen, the good hormone,
Yes.
because I do feel it's important that we do more education around the benefits of estrogen. Because what often happens is we read one article, just one, and it will completely sway everyone's opinion. It's just
That's
so
right.
amazing how that happens. And so the more that we educate around this hormone, and we are going to talk about the other hormones because nothing in our body works in silos, right?
That's right. Yep.
So I'm so happy to welcome you back, Debbie. Thank you so much for coming.
I'm excited to be back. Thank you.
So let's start with your background and why you do what you do.
Yeah. So originally I knew I always wanted to be a doctor. And I wanted to be a doctor that included, lifestyle and diet, nutrition, exercise, having the body move and do what the body does, and using the body to its benefit versus just trying to silo it out, if that makes sense. I feel like conventional medicine does a really great job of saying, okay, we're just going to focus on the eyeballs. We're just going to focus on the pancreas, and
Yes.
our body doesn't do that. We need it to all work to get, we need all of the cogs in the wheel to get a little, yeah, or in the machine to get a little bit of love. And so when I was looking at medicine, that's what I wanted to do. And to be able to do that, it was like, well, okay, so there's the medicine part, but then there's also the nutrition part, and then there's also the physical activity part, and there's all, like all these other things that we want to do. And naturopathic medicine was like, hey, here I am. I can do all of that. And when I started into naturopathic medicine, I really just wanted to deliver babies. And in looking at that, you realize, like, wow, okay, what does it take to deliver babies? What does that mean for the health of the mom? What does that mean for the health of the baby? And then it's looking at, women's health and hormones and all of that. So that's the big snowball that brought me into effect here.
Yeah, I hear that a lot from naturopathic doctors that, okay, I just have to say this, like, because I just heard this the other day. Um, because I understand there is absolutely a place for conventional Western medicine.
Yes.
Absolutely, there's a place for it. But typically, going to a general physician typically is not a great idea for diet and lifestyle because I heard this the other day and I was like, no. Somebody had told me that they went to their doctor, their kids weren't getting enough calcium in their diet. Their doctor said, have a Hershey bar every day. They told the mom to give their kid a Hershey bar every day to get their calcium. So I
What?
completely get where you're coming from because, as you know, I'm a nutritionist. So I'm like, oh my gosh,
Yeah.
people, listen, your doctor they have their function, but please see
Absolutely.
somebody that has been trained in nutrition.
Absolutely. And conventional care is really great for acute care. It's really great to make sure that if there are any emergency situations, they can get you stable. But I feel like functional medicine is that gray area where we really live our lives, right? And that's where we're making those decisions for what do we put in our mouth every day? What do we put on our skin every day? How do we support detoxification, right? Like that's the gray area of medicine that is the daily grind, I think.
Yeah, yeah. I'm so glad to have you here to talk about estrogen because
Yes.
I've done a number of shows on hormones, and I think starting at the beginning is very important. And with a doctor like yourself, you get where does estrogen enter? We have it
Yeah.
from when we're almost born, right? Or do we have it when we're born?
So we get a lot of estrogen from mom when we're in the womb, and then we don't. There's not a lot of activity in those hex hormones until we start puberty, right? And that's when we start to get that communication from the brain to the ovaries, and the ovaries start to wake up and kind of try to figure out what they're doing and how they're doing it. And when we think of female hormones in general, right? Like estrogen is the big one. She's the superstar. She's the queen. And progesterone also comes in to support that kingdom, right? So you can't have estrogen without progesterone. But estrogen's job is to help grow things, to help mature things, right? So estrogen is responsible for us getting body hair, pubic hair, hair under our arms. It's also part of developing that ovarian communication with our uterus, creating that lining. That's our builder. So estrogen is definitely a builder. She's a maker, she's a supporter, and that's what estrogen does. And we think about that. We also want to think about that in our bones and our blood vessels and our skin. Estrogen is also part of that construction as well.
Okay, you said estrogen is our builder. And, I'm probably going to jump ahead here, but maybe that's why people jump immediately to estrogen causes cancer because
Mm.
it's that builder, right? It's okay, but estrogen is also what makes us more feminine as well. Like
Mhm.
men have estrogen too,
Yep.
but obviously it's kind of like testosterone. We as women have testosterone as well, but if we have too much testosterone, it would give us more male characteristics. If men have
Right.
too much estrogen, more female characteristics. Does
Mhm.
that make sense?
Yeah, yeah, and that's not to say like, there's a place for each of those, right? Just as females have testosterone, we need a certain amount of testosterone to get the benefit. Same thing with males and estrogen. I feel like there's this, when we talk about males and estrogen, it's like, "Ooh, we don't want any estrogen," but estrogen
Right.
actually enhances how testosterone can do its job in males, and we wanna remember that for testosterone in females, right? Like, we we have a partnership in those hormones. It's just different in how it's expressed.
Okay, and they're both androgenic hormones
Testosterone.
and estrogen.
So I would say they support each other is what I
Okay.
would say with that. Yeah.
Can you
Yeah.
explain um can you explain that since I brought it up? You might as
Like
well.
androgenic versus
Yes.
estrogenic.
Yes.
So, and in my mind, and so this will be my interpretation of that, and I would love to have that discussion. When I think of androgenic, we think of more of the male properties, right? So we think of like muscle mass, facial hair growth, drive and libido. So that's kind of where I would put androgenic, where estrogenic I think is more feminine, as you were saying, right? Like that's going to be more of the curvy, and even emotionally like compassionate and thoughtful. That becomes more estrogenic to me.
Okay, you said emotional. So
Hmm.
maybe because I do want to get into the building side, but maybe it's a little bit too early because I want to ask you symptoms that women experience because what can happen in their 40s, they can actually have higher estrogens in their 40s and then it kind of goes boom, like as soon as you kind
Mhm.
of hit menopause.
Yeah.
What are the symptoms of high estrogen? And I know you're going to talk about it in relation to progesterone too. And then
Mhm.
what are the symptoms of low estrogen?
So I will say this, and I do agree this is going to be a frustrating point, and if I were in charge, I probably would have made this different. But when we look at the swing of the pendulum, right, like too much estrogen to too low of estrogen, you can have similar symptoms. So when we look at estrogen being too high, and as you said, this is also going to be relative to our progesterone, because there is the idea of estrogen dominance when we just look at blatantly high estrogen, or estrogen dominance that is high relative to your progesterone. Estrogen is when we have too much estrogen, it can feel irritable. It can feel, and when we're cycling, this can be, more intense cramps, heavier bleeding, clotty periods, more intense PMS, so emotional mood swings, migraines. Those kinds of things can happen with too much estrogen. We swing the pendulum to the other side, you can also have some of those symptoms, not all of them. You could still have some of the like irritability that comes with low estrogen. Usually, what we see with low estrogen as a primary symptom are like hot flashes and night sweats, but you can still get that with too much estrogen too. When we have too low of estrogen, we can also see like lower energy, lower drive and motivation. We can start to feel like the body just isn't performing the same way that it used to as well. Like your body just feels different too.
Yeah, and you hear this a lot for menopausal women. It's like they lose their joy for life. They lose their vibrancy. They lose that. And it's not even necessarily about being happy or not being happy, because things that happen in our lives can make us unhappy or
Oh,
happy,
yeah.
like throughout our whole life, but
Right.
for no reason, just losing that vibrancy for living.
Mhm. Yeah, where you're not necessarily changing anything, your circumstances are the same, you're still doing the same routines, but you're not as fulfilled or you're not feeling as, settled. Um, and there's when we start to lose progesterone, that can make a big difference with like maybe more increased anxiety and not being able to sleep as well. When we're not sleeping as well, we're not performing as well. So there's some of that that happens. But we also see that estrogen is really closely tied to serotonin, and they rely on each other to be able to do their job. So when we lose estrogen, serotonin loses its partner in helping to give you that, like, oh, I'm here, I'm happy, I'm feeling good. So serotonin can also be affected by those drops in estrogen too.
And then can't testosterone be part of that too?
Absolutely. Yeah. So when I look at those androgen hormones like testosterone and DHEA, they can have a big impact on like your sense of well-being and your drive. And I don't mean that just in like libido and sex drive. I mean that like in brain drive, like brain motivation. Like when you wake up for the day, what does that drive look like for you? Testosterone and DHEA can also influence that pretty significantly.
Oh, interesting. Because really, well, I guess in even younger than perimenopause, there's a lot of young women who experience low progesterone,
Oh, absolutely.
like a lot. And then that gives them estrogen dominant symptoms, even though
Mhm.
their estrogen levels might be where they're supposed to be at.
Right.
Right. So,
Yep.
I mean, this fluctuation in hormones can happen at any stage. And
Absolutely.
And I joked with my daughter, I'm like, listen, you're going through puberty. I'm in perimenopause. So, we're kind of both going through it.
Absolutely.
And there's different reasons for a young woman to have, low progesterone. What are some of those reasons? I just want to cover that because I think it's important. A lot of people who listen to my podcast also have young, like
Mhm.
daughters.
Yeah. And I think depending on the age, it can also just be kind of like the sputtering that happens with the ovaries, kind of getting into their swing and making sure that they're responding appropriately with progesterone. But they've also done some pretty interesting studies where they were looking at the stress response
Mm,
in older women, and I'm talking about 70 and older, and then younger women in their 20s and 30s. And what they found was the stress response was more intense in those younger females than the older females. And so the older females actually had better hormone balance than the younger females. And it has to do with our stress, the increased stress that we have just in our world today. And stress, right? When our body is stressed, the whole purpose of cortisol and our stress response is to keep us safe. So your body prioritizes your safety over any kind of sex hormone health, right? Like it's going to worry about keeping you safe before it's like, oh, let's ovulate so you can have a baby. Like it's not in that stage, right? It's going to be like we're going to put one foot in front of the other before we even think about any kind of fertility support, sex hormone support. So it will prioritize that cortisol before it prioritizes the signaling of your sex hormones. And so when we are in that stress circle, when we're in that stress bubble, you can find that maybe our girls aren't ovulating as regularly as they were because they're not getting that same safety signal, and their body's ready to jump into that sympathetic nervous system.
that makes sense. I used to always say, and I know this isn't the physician way of saying things, but I used to always say like, think of high stress all the time as like Pac-Man for like
Oh
this,
yeah.
right? It's like Pac-Man. It's
Yep.
just like eating away that progesterone. So
Yep.
I guess that goes with any woman at any age.
Yes. And this is where
Um,
we also see so that can create a slower progression to having normal cycles in our younger females, but it can create a quicker progression to irregular cycles in our perimenopausal females. And so this is where you have those 35-year-olds that are like, my doctor said I'm in menopause. Aren't I too young to be in menopause?
oh.
Yeah, your body is trying to prioritize safety over sex hormones, right? So that's where we start to see that also shifting too, I think.
Yes. Well, it's so interesting because I I I like to go back just as a learning, not because I can change anything, but when I
Right.
had a thyroid, I think about, okay, well, I had all the symptoms of postpartum thyroiditis. I wasn't producing enough milk. I had a baby that wasn't sleeping. I
Mhm.
wasn't sleeping. I was,
Same thing.
so, it's interesting when you go
Yeah.
back and you can kind of look at it and go, okay, you know what? I had some nervous system dysregulation going on
Right. Yeah.
and it was never diagnosed. And then, that was at 35. And then 41, I had thyroid cancer. And those nodules didn't appear overnight. I had
No.
them there,
Yeah.
for years. But then that's another tie in with thyroid.
Absolutely. And I mean, I've we can also see when the thyroid is not happy, that can also influence your sex hormones. And it it's very possible to see thyroid go a little wacky, as a technical term. And when that happens, you can see changes in your cycle, irregularities in your cycle. And maybe that also complicates that journey into perimenopause for some females too.
Yeah, yeah. So thyroid is definitely a piece of the puzzle. But
Absolutely.
let's get into some of the details on estrogen and
Yeah.
why it has been so. I purposely wanted to have a conversation surrounding the importance of estrogen and the fact that we've had it almost our whole life and why we have it.
Well, there's a
Because,
reason we
yeah,
feel better when we're, in our 20s, 30s, 40s, when we have our biggest boost of estrogen.
yeah,
Makes a
right.
big
And
difference.
so, how many women do you know? Like, I know I didn't even consider cancer from estrogen in my 20s. I'm not saying it doesn't happen. That's
Mm,
not what I'm saying.
right.
I'm just saying that, as far as I can remember, I've always had estrogen. So,
Hmm. Yeah. And there, I feel like, and this is actually a great time to talk about this because I feel like there's been a lot of discussion about, oh, estrogen's bad. Oh, no, estrogen's good. Estrogen's bad. Oh, no, no, estrogen's good. There's this big discussion happening, on social media. And the beautiful thing about social media is we have access to information. My concern about that is making sure that we're getting the right information out there. And I know that we want to make sure that people are well educated and that they have the education to make like they have the resources to make those educated decisions. Um, Unfortunately, I feel like and we kind of talked about this just before we got on here, was the WHI study,
mm,
which really, I think, shaped how medicine and people in general look at hormone supplementation, especially estrogen, as a supplementation, and that it's bad and it causes breast cancer and it's dangerous. And that was actually, when we look back at the original WHI, there was a republication of it saying, like, actually, when we look at the data, we're able to go back through it, we got that wrong.
yeah.
And I want that to be stated. Like, I feel like a lot of people don't know that that was restated. And I feel like a lot of people don't know what was restated in that. And even with the WHI, they were using conjugated equine estrogens, right? So that is a much more concentrated estrogen. But what they found was the women that were doing that estrogen actually had lower incidence of breast cancer.
Yeah.
And so that is a huge statement that I think has not, like, it's been kind of like the elephant in the room that people aren't talking about, but that was a huge outcome from the republication of the WHI. So I think that's important to acknowledge that as much as research is important, we we want to have a questioning eye to it of, okay, what happened in this study? Why did that happen? And what were the results from that? And I think we can, outside of just blatantly trusting when stuff like those are big statements, when those things come out, like, great, let's actually see what contributed to that research and information.
I'm glad you mentioned that because what I am going to do for anybody who's listening, I've actually put a little note that I'm going to make sure that I put the updated study in the show notes so that you can take a look at it yourself. And I always say this, Debbie, like we need studies. We have to do studies, but it doesn't
Absolutely.
mean that they can't be wrong sometimes or that they can't be slanted or biased. And actually, one of the courses that I took when I went back to college for nutrition was to understand studies and to be able to
Right.
decipher. And I understand that not everybody listening to this podcast is going to go and do that. I get it. But
Yeah.
that's why we're not saying in anything definitively, this is this and this is that. But what we can say is when a study has been retracted, there's a
Mm-hmm.
reason for that.
Mm-hmm. And a big reason, especially in such an influential study like the Women's Health Initiative. It was huge. And it shaped how medicine gave that um, interpretation of hormone therapy. It hugely
Still,
shaped it. And even
it's
to this
still.
day, exactly. Like, I still talk to people that are like, well, my mom had breast cancer, so she told me that I can't ever look at hormone therapy. And
Yes.
based on information that they were given at that time, understandably, but we need to have a bigger conversation about it. And we also need to recognize when we're looking at estrogen and how estrogen works in the body, estrogen has, alpha, there's an alpha estrogen receptor and there's a beta estrogen receptor. And these can be influential in disease processes, right? So when we're looking at alpha versus beta, that can also influence if the estrogen is going to be more aggressive versus protective. And so it's also taking that into consideration. There are nuances in hormone physiology that we want to keep to the front of our mind when we're listening to all of the discussions that are happening about estrogen.
So, perfect time to say, why is estrogen protective? What does estrogen do for us as we age and as we go beyond menopause, even?
Yeah. So what we have found is for women that are postmenopausal, we enter a different mortality risk, right? We have increased risk for cardiovascular health. The number one reason for female deaths is cardiovascular health, right? And that changes once we become postmenopausal. So that would beg the question, why would that be? What happens in that? What are the shifts that happen there? We do know that our quality of life changes significantly. And now that women are living longer, we want to make sure that our quality of life, perimenopausally, postmenopausally, is good. We want to make sure, not just for ourselves, but even if you look at the medical system, right? Like if we can reduce the cost of healthcare, in
Yes.
having less bone fractures, right? So when we think about bone density, and estrogen is a big key player in making sure that our bone density, our bone health stays strong and healthy, right? That's huge. We look at cardiovascular health. And I would say that this is an area where I think we could still do some more research and looking at how estrogen does influence cardiovascular health. But if you think about estrogen just superficially, when we start to lose estrogen, we start to get wrinkles. We
Yes,
start to
we
get
do.
thinner skin, right?
Yep.
That's not just on your skin. Think about that in your blood vessels. Think about that in all of the areas that um, elasticity is important. When we have good estrogen levels, we have good elasticity in our blood vessels as well, right? So our blood vessels need to be supple, they need to be able to pump all of that blood. When we don't have that same suppleness, it makes it more difficult for our blood vessels to pump. So that's where we look at like blood vessel health and cardiovascular health with estrogen. We also know that it influences cognition and our brain health, right? Like the juicier our brain is, the better it works. Can estrogen influence that? Absolutely. And so these are things that we look at, postmenopausally, oh, like brain fog. You may not feel your bone density until it's much later, right? Like you aren't going to actively notice that until something could happen, right? You fall and a fracture can happen. That's where, in looking at estrogen and its support, is really key and important.
Yeah. Well, and the other thing, you just said it there. It's like, think of estrogen as the lubrication for everything,
Mhm. Oh,
right? Like
yeah.
it's
Joint spaces,
yes.
our ears, our eyes, our nose. And this is, different than like if you have any of the like Sjogren's or dry eye disease. But this is where you start to see that shift when you lose estrogen, where you're like, my eyes are all of a sudden drier. Like I don't know what's happening. Or I feel like I'm parched all the time. Or a big thing that happens is joints. Frozen shoulder is a big thing that can happen in perimenopause and menopausal females, or other hip pain, joint pain, knees, like just getting that lubrication, that changes a lot.
Yeah, and of course, there's the whole vaginal lubrication too, and
Absolutely.
inability to be able to have sex. It's too painful. You hear that
Yeah.
all the time.
And even with that, also just like, hey, it hurts to pee, right?
Oh,
Like
yeah.
that is also huge too.
And it's I find it just so interesting how there's the generation when my mom was younger, and very few women were doing any kind of hormone therapy at that age even. So this is
Yeah,
before that WHI study came out. And, you know, I see so many women that have dementia like now that are older,
yeah,
like in their 70s and 80s, and they're living a long time,
right.
but with dementia. So, there's just so many factors there that I find a little bit more alarming than going on bioidentical hormone therapy. Personally, that's me. That's
Yeah.
my choice.
Right. Yeah. And this is always going to be an individual discussion with you, your comfort level, and the discussion with your provider, right? Because you have to do individual risk assessment. You have to look at, what has happened in your life history as well as your family history, what your environment is, right? Like if you are a stressed out mess, I would love to say that one pill could cure it all or one patch could cure it all, but that's not the case, right? So I think there's definitely that individualized approach for sure. And you did also say something where you had mentioned bioidentical hormones. And that I think is also a part of the discussion when we look at synthetic hormones versus bioidentical hormones. And that is also a big part of the conversation.
Yeah, let's break that down because I do know that uh, honestly, Debbie, I find it almost shocking how few women think what they're getting from their general physician, progestin, is
Yeah.
progesterone, and it's all the same. It's not all the same. So could you get into that?
Yes. And I will say, I feel like this is I see this in the conventional medicine world a lot, unfortunately. And even in research where progestin is, um, I don't know if it's intentional or not, but so progestogens are an umbrella term that includes progesterone and progestin. So a progestogen just means some sort of progesterone. Now, there's a big difference between a progestin and a progesterone. Progestin is a synthetic progesterone. And when we look at a synthetic progesterone, it's mostly molecularly similar to progesterone. So it'll still hit that progesterone receptor, it'll still dock on there, but we don't know what else it's signaling based on its molecular chemistry. When we look at progesterone, progesterone mimics our progesterone. It can sit on that receptor, but it only does what progesterone is supposed to do. It doesn't signal other things. It's not confusing to the body. So, this is where we can see that big difference between a progesterone and how that is supposed to influence your body versus a progestin. We often see progestins like even in the Women's Health Initiative study, the progestin ended up having a little bit more of a like a thrombotic risk. So a little bit of thickening of the blood, um, even though there were some protective parts to it, but it acts a little bit differently than progesterone. And even in like a lot of the testing that I've seen through Dutch testing, we can see that progestins can have a little bit more of like an estrogen effect, which is very interesting.
Hmm, that is interesting. Now, what about estrogen? Because this is where you kind of see a bunch of different things. You see oral estrogen, you see the
Yep.
gels, you see the patches, you see um,
Creams.
creams. Like, can you break that down for us?
So estrogen, and I will say, and so I'm in the US. I know that you're in Canada, so there might be differences in what is available. Um, for There are certainly synthetic estrogens that are available for supplementation. I'm going to be more a fan of the bioidentical estrogen, so estradiol. And you can get estradiol in many different forms. The patch form, as you said, creams, gels, they have sprays, they have vaginal inserts, they have oral tablets, they have troches. Like there are all sorts of opportunities to supplement estrogen. Um, there I think it's important to know how each of these works in the body to know what might be a better fit for you. The other thing that we have seen just in a lot of research is that transdermal estrogen, so that's going to be your patches, your gels, your creams, some of the sprays. These are generally, well, we'll categorize that as generally the safest form of estrogen or estradiol. The oral estrogen I know is also common, and there's a caveat with this safety, meaning whenever you take anything orally, it does have to go through the liver and the gut to get metabolized. If you have any risks for blood clotting issues or anything like that, that's where you want to be careful with oral estrogen because once it hits the liver, it activates those clotting factors, and
Hmm.
that's where it can be a little bit more risky. Now, that said, we can still see great benefit with oral estrogen. It just comes with an additional risk to evaluate there.
Okay. Yeah, I've heard the exact same thing. That and then so I'm on biased,
Mhm,
which is I think it's generally 80% estriol and 20% estradiol.
mhm,
What's the difference between estriol and estradiol? I know I've heard some practitioners who say it's not effective. I haven't had any issues personally. I find it great. And I've heard some doctors say it's just a safer option to do it this way because estradiol is more potent, right?
mhm.
What are your
Yeah,
thoughts
so
on this?
yeah, estradiol is generally that potent hormone, where estriol is a weaker hormone. So you still get effect on the estrogen receptors, but it's much weaker, like 80% weaker than estradiol. So estriol is really great as a local, especially for vaginal dryness. Those vaginal cells love estriol, and estriol can get in there and support that vaginal lubrication really well. But estriol is definitely weaker. Now, and it's interesting to talk about this because I feel like when we're looking at something like biased, depending on how much estriol is there versus how much estradiol is there, we know that the estriol can dock on those estrogen receptors. And it's really looking at that preference. And if you're doing like the standard dosing is kind of what you're on, like the 80-20, so the
Yeah.
80% estriol, 20% estradiol. We see that estriol kind of crowds those receptors so that you're getting more of the estriol effect, but you're still getting some of that estradiol effect. So you're still getting this like softened effect of the estradiol when you're doing something like the biased.
Yeah, I mean, I know for me personally,
Yeah.
it works because I started to do estrogen therapy, before that whole 1 year,
Hmm.
no periods, which I personally, and this isn't any advice, by the way. Like I'm not a doctor, but I'm just telling you that I think it's it would be horrific for me to suffer with hot flashes for a year before any doctor would do anything.
Yeah,
And
I agree with that.
I'm so happy I found a doctor who supports the methodology of once the symptoms begin and the tests show that it's clearly my estrogen's low,
Right.
so for me it makes sense because I started when I was kind of like, I got a period last year. So I wasn't in what they would call over that 1 year mark.
Like true menopause. Yeah.
Right.
Hmm.
Right. So it's a gentler form is basically what you're saying.
Yes, the estriol or the biased form. Yeah, it's not as blatant
Yeah.
as
Yeah.
estradiol. And some women do, like if they, I think this also depends on the person. You have some people that are very sensitive to that estradiol, and that's where estriol might be like, let's soften that and, get you into that sweet spot. And there are other women that are like, I need like the full thing. Like I need the estradiol, like give me the estradiol. So, and that's where again, like that individualized approach is going to make all the difference. Where you're at in your cycle history, where are you in that, menstrual history, right? Like, are you still cycling? Are you perimenopausal and you're kind of cycling maybe? sometimes? Or have you been postmenopausal for that, 360? Did you get the crown for the
Yeah, the
menopause
crown.
365-day, you passed the gate? So, and it's going to make a difference. And there are, like when we look at some of the guidelines, right? Like the Canadian guidelines, the NAMS guidelines in the US of where and how to start people on hormone therapy. And if you're still cycling, or for whatever reason you had a hysterectomy, your body will require different needs, right? So your dosing may be different from someone else who's been menopausal for 7 years, right? So it's also looking at those different components of what's happening in your life.
Isn't estriol the hormone, the estrogen that's highest when you're pregnant?
It is.
Okay,
Yes.
you're gonna love this, Debbie. So, and again, please, anybody who's listening, understand that this is just for informational purposes only. Okay, this is nobody's talking about medical advice here. But I actually use a little bit of estriol around my
Oh
eye
yeah. Hmm.
and on my neck.
Hmm.
And because I did a lot of my own research and I was like, oh yeah, everyone talks about the pregnancy glow, right?
Hmm.
So it kind of made sense. And then I was reading that um, estriol's difficult to actually capture in blood serum in terms of elevations. I was reading a bunch of research on this.
Yeah. So there,
But
whether it's
urine's different though, right?
so the difference with that is when we do, whether it's estriol or estradiol or even progesterone, the way that our body, like if we were to do a blood draw every hour of a 24-hour period, we would be able to see how those estrogen levels change. There is a significant up and down pattern that happens with our hormones. When we do like dried urine testing, it's a pool of those. So you get a better average of what that looks like versus a singular point in time, which we don't know if that singular point in time was when you were peaking or when you were troughing, or maybe you were in the middle. Like we don't know that unless we do your blood draw every hour, and we've done that for you, and we can do that like on a more consistent basis, which is where something like dried urine testing will be able to see that pooled value. So yes.
Okay. Ooh, okay. So since we're on that, if
Mhm.
I'm taking something like a biased, I am taking, and what I'm biased, just for anybody who's listening, it's just a cream. And then I'm also taking progesterone compounded capsules orally. How would I go and test on the Dutch? What do I have to stop taking it?
So if it's topical, you do not have to stop taking it. So you can still do your therapy for your biased. That will be fine. That will give us a good idea of what your levels are on supplementation. The difference is when it's oral. So that would be both for progesterone and for estrogen, because what happens is, again, that same thing where it goes into the gut, we call that first pass metabolism, ends up dropping a lot of metabolites into the urine. So that's what we can see with oral progesterone. We can also see that with oral estrogen. What we usually recommend is taking a break like the day prior, so we get a little bit more of a like a true therapy response versus it being, I don't want to say falsely high because that's not true, but it makes it look higher than it is.
Okay, so then if for anybody who's listening, if you are on oral progesterone, you can stop 24 hours before you do the Dutch test.
Like skip that night before,
Yeah.
and then go ahead and do your testing like normal, and that should be fine.
Okay. Okay, that's
With
good to know.
estrogen, so and it gets a little tricky with estrogen because it really also depends on how well your body is detoxing things, how well you're absorbing it. And we've had this discussion of like, do we have you stop the estrogen like the day before, or 2 days, or 3 days? Because depending on how well your body is detoxing things and absorbing things, we can see some people that we're able to see where that supplementation is after 1 day. For other people that are a little bit more sluggish in their metabolism, it can take up to 3 days to see that.
Mm,
So I would say about a 2 day average of being off of oral estrogen would still give us a decent idea of your metabolites and how your body is metabolizing your estrogen. It's not a great way to monitor, like, is that the estradiol level that we want to be at with oral estrogen?
okay. That's good to know because like I once did a blood test. It was a fasting
Hmm.
blood test. It's a home test that I do now and again, but it's more about the biomarkers, but they just so happen to have added on the hormone panel. And I had
Yeah,
done my estrogen cream right before bed, and my
yeah.
estrogen was through the roof
Oh,
in
yeah.
fasting blood the next morning. I'm like,
Hmm.
oh my God. And then I had to redo it because I forgot that I should have stopped it.
Well, and there again, like, even if you're not supplementing, right? Like, if this is just you as a cycling female, we still see like that up and down pattern with the estrogen and progesterone. So you can still get a good, I would say if you were to do a serum draw, you still get, you're somewhere in there. It's just looking at the average of those, right? So if you do one cycle, you do another cycle, you do another cycle, and you try to do it around the same time. So is it going to be in the morning, in the evening? That's what we're looking at really, is that pattern versus just that one singular point in time test.
Yes. Okay. And for anyone who's listening, if you want to know more about testing, I actually recorded with Debbie, I think it was about a year and a half ago on testing. So I'm going to put that in the show notes as well because it's, testing can get a little bit confusing.
It can.
It definitely can. Okay. So we covered off really the pros and the cons, the differences between bioidentical. I think it's very important to talk about the cancers that are, and oh my gosh, Debbie, I had a post, on the post I actually just said estrogen doesn't cause cancer. Do you know how many people got angry?
Oh, I can imagine.
And listen, I wasn't trying to, be controversial. I was just saying, okay, well, it's not the what, it's the how. It's like what's
Mhm,
happening to it. Yes,
mhm.
estrogen is involved, but it's not, we've had it our whole lives. So let's get
Yeah.
into this conversation. I think it's important.
Well, and there are certainly, like, if you have estrogen receptor positive breast cancer, like, yes, that is going to be an estrogen driven cancer, and we want to be mindful of that. And I think it can be difficult to make blanket statements of estrogen causes cancer. We want to look at estrogen in all of the other components, right? Like, what's happening with their progesterone? What's happening with their oxidative stress? What's happening with their cortisol? What is happening
Yes.
with their environmental exposures? Like, is it just estrogen? Now, that's an easy thing to target in on because there are things that we can do to reduce that estrogen effect in the body, right? Absolutely. We have the technology, we have the science to be able to stop that estrogen effect on those estrogen receptors. It's I don't know if I want to say easy, but it is a well-researched way to block the estrogen effect. And it is um, a singular way that we can do that. Now, does that address any of the other things that are happening? Was it because there wasn't enough progesterone? Was it because there were some other genetic things that were going on? Was it because there were some other environmental influences that contributed to these? Those are the unknowns, right, that we don't know about.
Yeah. So here's the thing. I think that, people getting angry about me saying estrogen in and of itself, because you just said it. You just said it. And I'm this isn't about judgment at all. It's about like you can't say one thing. It's just like
Yeah.
genetics and epigenetics. So my aunt died of uterine cancer. Okay.
Yeah.
And while I know there were other things going on, she wasn't a drinker, she wasn't a smoker, she was overweight. I'm sure there's some genetics there. I know myself in my 40s, I was always estrogen dominant. So I know that I have to be careful and
Right.
cognizant of those things.
Right.
So that's not, but what I'm saying is that if I was to go and drink a bottle of wine every night and cook dinner or eat takeout and do all those things, well, I know that can put me at more risk.
Right. Absolutely. And it's understanding those risk profiles and understanding what causes inflammation in your body and understanding how your body's detoxing, looking at genes that help with detoxification. I mean, even the WHI study that we were talking about has shown that women that were on estrogens alone had less risk for breast cancer and better outcomes with breast cancer on estrogen alone. That's not even paired with progesterone, right? That's just estrogen. And those are conjugated equine estrogens, so more concentrated estrogens. Their breast health was better.
Yeah, and that was that was the oh right with the progestin, correct?
That would even just estrogen alone. Estrogen
Oh,
alone, and that's what I'm saying, not even with the progestin, not even with progesterone, just estrogen alone. They had less risk for cancer, better outcomes for breast cancer.
wow. Do you know who Dr. Rosensweet is?
Yes.
Yeah. So I interviewed him and he was talking about the fact that what people don't really understand is that hormones in and of itself are actually, what's the right way to say this? Cancer prohibitive? Is that the right way? Am I saying
Oh,
like
okay.
he's
Like
saying that
anti-cancer.
the the absence of hormones that can actually put you at more risk for many different kinds of cancers.
Well, and if you look at Rebecca Glasser's work, she's talking about injecting testosterone into breast tissue that is reducing tumors.
Really?
I mean, so there are studies, there's research that is coming out supporting this because breast cancer is huge, ovarian cancer huge, uterine cancer huge. Now, breast tissue is different than uterine tissue is different than ovarian tissue. So we want to look at those individually as well. But yeah, and this is where we look at, again, those nuances of hormones, right? Is it an estrogen alpha receptor? Is it an estrogen beta receptor? What is the difference there? How does that influence your inflammation or your estrogen response? Like, that is also something to take into consideration.
Okay, but regular blood tests won't tell us that information.
No,
So how do we
actually,
know?
great question. I don't know how to test the alpha versus beta receptors for
Do we-
estrogen.
Can we do that? We can do that in the Dutch or no?
No. Mm-mm. Now we can see not for estrogen, alpha and beta. In the Dutch, you would be able to see how you're detoxing, what those levels are, how that compares to your testosterone, how that compares to your progesterone, but not the individual receptor variability. That I think is going to be more into like genetic testing.
Interesting. But the Dutch test can tell us some very important information
I think
on
so.
how we're metabolizing estrogen.
Yeah, like do you go down the preferred pathway, which is that 2-hydroxy pathway, which can easily get those estrogens through detox? Or do you go down the genotoxic pathway, that 4-OH or the 4-hydroxy pathway? That one has a lot more potential to become dangerous, make changes to your DNA. Or are you going down the 16-OH or the 16-hydroxy pathway? Now, the 16-hydroxy pathway is what we call a proliferative pathway. It grows things. Good for bone, not so great for breast health and ovarian health. So this lets us know, like, what is that proliferative capacity for you? Are you able to, like, when we're looking at detoxification, we want to make sure that we can grab your estrogens from the estrogen receptor and clean it off and then send it through the body. If you are holding on to those estrogens, it's harder to take them out and clean them off. They become more dangerous. So that's essentially what we're looking at in that metabolism pathway in the Dutch test.
And that's where you're talking about detox and recircling the
Mhm.
estrogens because really, there's many factors like, are you pooping every day? Are you,
Right.
right? Like there's so many different things that
Mhm.
would affect whether or not those estrogens are circulating within the body,
Yep.
right?
Yeah. The more your body has to clear, the less opportunity it has to make it clean. Right. That makes sense. Like the more it has to go through the same process, it has a chance to wiggle through and be dangerous.
Okay, so is it possible for a woman to, because there are some protective, like supplements, food
Hmm.
as medicine
Yeah.
options
Yeah.
that are protective. Like I've been on, at one point, I was on DIM and it was just a little too intense, the
Mm,
dosage. And then it's like it took too much of my estrogen away
yeah.
because it's phase one, right? DIM is,
DIM is mostly phase one. Yep.
yeah. So can you get into DIM versus sulforaphane versus
I love sulforaphane.
calcium deglucarate?
Yeah. So DIM is very focused on phase one metabolism. And it's that concentrated form. It's a what I'm looking for, constituent from broccoli. We did try the experiment. We were trying to figure this out. Can you eat enough broccoli to equal the amount of DIM? And it's
Yep.
way too much broccoli.
Yeah.
Um, but DIM really helps to go down that 2-hydroxy pathway. But we can see this, even though research doesn't support this. This is really interesting. Research says that this doesn't happen, but anecdotally, we see that it can lower estrogen levels. So it depends on what your goal is with the DIM. Now, a lot of times people will use DIM with other things like NAC or CoQ10, just to kind of help support that detoxification pathway. But DIM is very specific to phase one. Sulforaphane, which is a little bit different than DIM, can work, it does work on phase one, but it can also influence phase two, which is methylation, a little bit, just because of its overall detoxification. We don't see that sulforaphane lowers estrogen the same way that DIM does. And then calcium deglucarate is really an important factor in like that phase two to phase three clearance. I think of it really more as in the gut versus phase one and two are in the liver. Calcium deglucarate works on an enzyme called beta glucuronidase. And what happens is you get all of your estrogens, they get messy in phase one, which is what they're supposed to do. Phase two tries to clean them back up so it can send it into phase three in the stool. By the time you go from phase two to phase three, what's happened is your phase two metabolites, essentially, or that metabolism essentially gets your estrogen all packed up in a nice little package to send it out in the stool. And what beta glucuronidase will do is it'll take that package and blow it up. And like, oh, I just released all the estrogen back in. And that's what beta glucuronidase enzymes do. So if you have a lot of beta glucuronidase, you end up having a lot more estrogen that gets recirculated back into the body. Now, calcium deglucarate helps to reduce all of those enzymes so that they don't come in and destroy that nice little estrogen package that's supposed to go out in the stool.
Can I ask you now to find out if you have that, you would do stool testing, right?
Very specifically, beta glucuronidase.
Yeah.
Yep.
Okay.
And you can do that as a singular test. Sometimes it will be part of a package depending on what stool testing you're doing. But if you have high beta glucuronidase, it likely means you're not going through phase three clearance very well. And it also likely means you're getting a lot more estrogen recirculated back into the system.
But the Dutch test won't show that anywhere. It just 1 and 2
It's
in the
not
Dutch, right?
just 1 and 2.
Yeah.
Yeah.
Okay.
Now, calcium D-glucarate, like that's where it really shines is in that phase 3 and that beta glucuronidase activity. So that's where we can see beta glucuronidase being really helpful.
So what would be some signs that somebody should not just do the Dutch, but also do gut testing? How would they even know?
Oh, yeah. I mean, when you're looking at hormone symptoms, right? If you, one, are having not so great periods, so significant PMS, really intense breast tenderness, or fibroids, both in breast and ovaries or uterine fibroids, clotty periods, heavy periods, acne, like a lot of those kind of PMS symptoms that come and go.
Mm,
Um, that's what I would also look at. And if you're, also looking at gut health, right? Like if your gut is not happy, you have constipation, diarrhea, you're not absorbing things very well, you're not detoxing things very well. When we look at gut health, I would also consider that.
okay. Now, just to kind of simplify it, and of course you have to see your own practitioner. Again, I have to say this again that
Right. Yeah.
this is not because everybody's so unique. I know for me, I have been taking sulforaphane for a long time. I feel like, and this is definitely not making any kind of medical claims at all. I just feel that, whenever I do my Dutch test, my pie chart looks much prettier, right?
Yeah.
Like
Yep.
it just like everything kind of seems to be more in place. And just to explain, maybe explain how the visual is on the Dutch.
Yeah. When we're looking at especially the pie chart, that visual representation, what we're looking for is about 75% or three-quarters of that pie to be green. And that green represents that 2-hydroxy pathway, which is that preferred pathway for detoxification. You're going to get a little tiny wedge of red, which is the 4-OH pathway. That's the dangerous pathway. There's probably going to be some just because it
Yep.
exists. And then there's the 16-OH pathway, which is going to be a little bit less too. So I would say, like, a tenth of that pie chart could be the red or the 4-hydroxy, and then the rest would be that blue, is really what we're looking for. So we really want the majority of that pie chart to be green. We want to know that your body's able to pop off those estrogens from those receptors so it can clear your estrogens well.
Yeah. So what you want to do is I've been taking the Dutch test since my 40s, and I remember working with a Dutch test practitioner, and I feel now like I can look back and go, okay, it was a little bit of an intense treatment of me as a patient because initially that piece of the pie that's not supposed to be red was really big.
Oh,
And so
yeah.
that's how I knew I had some issues. And so the response was, "Oh crap. We better, we better do something fast." And
Yeah.
so anybody who's listening, work with a Dutch test provider because I'm going to tell you I've been doing one probably for the last 10 years at least. And I personally do it once a year because I do know my risks and things can change.
Mhm. Yeah, it would be great if our systems were static. That would make treatment so
Right.
much easier. But we're not. We're dynamic beings, and we want to be able to check in on that, see how we're doing with that. How can we best support our bodies in that dynamic process? I mean, that's what makes us really cool as humans.
Yeah. And we're all unique. Like so,
Yes.
you know, Dr. Rice and I were talking about how, like things change and even still like I'm 54 and I still feel like sometimes I'm simulating a period.
Hmm.
And, it almost feels like I'm going to get a period. Mind you, I had one in September. This is now February. So I think I'm still kind of in that kind of, middle,
Right.
not
Yeah.
really on the other side yet.
Right.
So this is just a really important conversation, but I can't end the conversation without discussing why are there still like so many of these fear-mongering articles that just come out? I
I
don't
will
get it.
s I know. I would like to say that I like to see the best in people, and I understand that my hope is that their intent is that they want you to be safe, right? They want you to be safe. And as far as their scope of understanding, their scope of practice, they're going to tell you what it means to them to be safe.
Mm,
But that's where I would encourage, like, yes, whenever you're looking at information, take it with a grain of salt. Do your own research behind it. If if you see this article that says estrogen is bad, but then you see another article that says estrogen is good, there are two sides to every story at least, right? So make sure you have a well-rounded view of the information that you're getting.
yeah, that's good. I mean, it's good advice because we get a lot of advice thrown at us,
Oh,
and
yeah.
it's
Oh,
important.
like information super highway with social
Yeah.
media. And then you're like, well, this person said it's okay. This person said it's not. Who do I believe? How do I trust this? And that's where, like you said, Sandy, like not everybody's gonna go back to school to understand how to read a research paper. So we still want to be able to understand the information that people are giving us. And that's where I say don't just look at one source of information. You need to have well-rounded sources of information, I think.
Yes. So, because I've always said this, Debbie, I've always said, you know what? For every single article or study that says don't do
Mm.
this, I can find one that says do this,
Do this exactly.
right? It's so true
And I mean,
though.
in the world, to be fair, right? In our world, we also want to be very cognizant of who's funding these studies,
Yep.
um, and what their alliances are. So, and I hate to say that, but I think it's really important when we're looking at medical advice, your quality of life, what that can mean for you. So I just don't be singular.
Yeah. Actually, and I'm writing about that because I am writing a book and I have written I believe we all must learn critical thinking skills. Do not
Exactly.
believe everything that I'm posting on social media.
Right.
I want you to go and do your own research and go, okay, maybe this isn't for me. And that's
Yeah.
fine.
Well, and I think it's fair to have an educated conversation. If somebody comes to me and says, "Hey, you said this. I have a question about it because I was reading this. Let's talk about it." I'm not going to say, "No, everything I say is right." You know, things are consistently changing. Research is changing. Our understanding of things are changing. Remember when vitamin D used to be bad? Remember when eggs used to be bad, right? Like things are always changing. And so we can have an educated conversation. Please come to me with any of those questions and concerns. Like, I want to have that conversation. I want to learn. I want to be better. We want to do better.
We do. But we do have to learn that we cannot just get fed all the information and that we
Yep.
just take it all in. So even you just mentioned vitamin D, like something came out not that long ago about how vitamin D can be bad for bones. And I'm like, but there was
Right.
never any mention about taking K2 with it.
Exactly. Or
Right.
any of the other minerals that help to
Yes.
support bone. Yeah. Yeah. Yep.
You see what I'm saying? So
Yep.
when you use critical thinking skills and you go, okay, wait a second, you know, this doesn't seem right. How could vitamin D be so important? And now they're saying don't take it or
Well,
be
and there was
careful.
that one study too that came out in, I think it was in Europe, that was saying you shouldn't take progesterone, that progesterone was dangerous. I can't remember. I'm totally gonna botch that. But when you actually read the article, it's talking about progestin,
Uh,
not progesterone. And so if you were to just, read the headline, you'd be like, "Oh, that's bad." But then you look at it and you're like, "Oh, but if I use my brain to read through what that's saying, it's not correct."
yeah, there you go.
Mhm.
Well, I think this has been an amazing conversation and a really important one because I think that we broke down all the information. And then, of course, it's for you to have a discussion with, and I always have to end with this, with a qualified practitioner.
Practitioner,
Not
yeah.
if your family doctor is not qualified in specifically customizing a hormone protocol, find one that
Right.
is.
Yeah, and it's okay to advocate for that. Absolutely.
Yes. So
Yeah.
please let us know, Debbie, is there anything that maybe we didn't touch on that you want to touch on?
I don't think so.
We covered a lot of ground. I know. I
I
know.
mean, we could probably talk for many more hours, but
Yes.
I feel like that was a good run.
It was. It was. Where can we find you and more information?
Yeah, so my Instagram is drrice.debbie. And since I also am a fan of Dutch Test, you can also go to dutchtest.com. Lots of information and educational resources there as well. Another person who I absolutely love and learn a lot from. I mean, there are so many great authors that are going out. Uh, Actually, one of her recent books, this was Dr. Lindsay Bergson, Safe Hormones, Smart Women.
Oh,
It's a
good.
great book. And she does a lot of talks. So if you can find her information, she's super helpful. Felice Gersh is also talking about hormones and hormone therapy. So there are a couple of plugs for them. They're great.
Yes, I've actually seen a couple of Dr. Felice Gersh's talks, even on mammograms. It was very interesting.
Yes, yes. Yeah,
Yeah,
she's got some great info.
very, very good. Thank you so much, Debbie. I really appreciate your time today.
Of course. Thanks for having me. I love it. Love being with you.
You too. Okay, I hit